excited that Dr. Jim Neel is giving us some of his time this morning. He's Medical Director for Population Health Management at St. Joseph's Health in Sonoma County. To tell you the truth, I don't know what that is. So I'm not going to do a whole bunch to explain it. I'm going to let him explain it. But he said this is the system of delivery of care that's going to be coming in the next few years. So we're on the cutting edge to get to have him here telling us what the heck it is and how we can use it. Dr. Jim Neel, thank you for being here.
I think I'm all set. Am I all set?
No.
Hold it. Make sure this works.
I'll check that.
Well, I certainly appreciate being invited to speak today. The topic I was assigned was population health management, and part of that is actually integrated care. It actually is relevant to everybody here in the room. This is sort of the future of healthcare. It's sort of a paradigm shift in how we deliver healthcare. So for all of you in the room, as I listen to everybody introduce yourselves, it's relevant to every single person, every single organization that's represented today. The current system of healthcare hasn't worked very well, and so changes had to be made. And the reason it doesn't work very well is because care is fragmented. We've operated historically in what we call silos. So when you're in a hospital, that's a silo. If you go to a skilled facility, that's a silo. If you go to home care, it's a silo. If you go to your doctor's office, it's a silo. It hasn't worked very well because we operate as silos, so we don't communicate as well as we should. We have multiple providers, multiple settings, multiple payers, and as a result, we have problems. We have poor communication, poor accessibility, poor accountability, and unfortunately, as a result, historically, relatively poor quality. Going forward, expect to see changes. First change is, every day, 10,000 individuals become Medicare eligible. Second, healthcare costs, as you know, are going up exponentially. Third, the cost of providing that care, as it goes up, has fewer dollars to feed it. We're shifting to what's called value-based purchasing, and I'll talk about that in a second. There's greater accountability for both cost and quality for all of us as providers. There's all sorts of new legislation we haven't even seen yet, and finally, we have rising technology costs, and technology is going to drive much of what happens in the future. Now, to give you an idea of how we're doing, we spend about 20% of our GDP on healthcare, which is a huge sum of money. And if you look at it, the United States alone spends as much as the next 10 countries, largest countries in the world combined. The problem is our outcomes have ranked only 37th. So we're spending lots and lots of money, but we're not getting much bang for our buck. Also know that in California, there are two initiatives that came out of a think tank in Berkeley. The first initiative was to cut from 75% to 50% those patients receiving fee-for-service care. In other words, shifting them into managed care. And to double from 30% to 60% those receiving care in what are called fully integrated or highly integrated healthcare systems. So that's where everybody thinks we're going. We also have, everybody knows, healthcare reform, the ACA, and the intent was to move from this silo or episodic model of care to population health management. We're going to talk about this. And driving that, we have the triple aim, and this is the challenge for all of us. We're supposed to lower our costs of care. At the same time, we're supposed to improve our quality. At the same time, we're supposed to improve the patient experience, patient satisfaction. So we're supposed to move from what we call reactive care, you get sick, you go to the doctor, to what we call proactive care. And there is a shift from the government to those who are paying for the care and those who are the providers. And what I mean is the following. The government has tried for years to rein in the cost of health care, and they really haven't done that very successfully. So what they decided to do is to shift that risk to the providers of care and let them fix it. Basically saying, here's some money, we're not going to give you any more money. You figure out how you're going to spend it, but we're not going to give you any more. And actually, that's a very clever thing to do. We as providers, for example, in the acute hospital environment, are responsible now not only for what happens within our four white walls, but we're now responsible for what happens after patients leave our facility. And that's a big change. We can no longer operate as a silo. We have a number of areas where this is true. These are 6 diagnoses. That's total hip replacement, total knee replacement, obviously COPD, pneumonia, acute myocardial infarction, and congestive heart failure. So if we discharge a patient from the acute care hospital and they come back within 30 days, that's tallied by the government. And if in fact we admit too many patients, we are financially penalized now. We as providers, and I include all of us in this room, are now going to be accountable for care across this continuum. For those in Golden Living, for example, is here. For those in the skilled arena, in the very near future, if you admit a patient to Golden Living and that patient rebounds back into the hospital and you exceed certain metrics, there's going to be a financial penalty. So they're shifting that risk and they're trying to hold people accountable for outcomes. We now have 6 diagnoses on the acute side where we're responsible if those patients come back into the hospital. In the future, we expect those 6 diagnoses to explode. Many more than 6 diagnoses. And in addition, now we're accountable for what happens if those patients are readmitted within 30 days. There's talk to increasing that time to 45 days or to 60 days. So the stakes are rising. And finally, at the same time all of this is happening, there is an increasing emphasis on quality and outcomes and safety and efficiency. So there are all sorts of data points and metrics that are being collected with financial penalties associated with them. Now, that brings me to shifting the risk. Does everybody know what bundled payments are? Everybody has a pretty good understanding of bundled payments. I don't need to say too much about that. Explain it. In a bundled payment, what the payer does is they go to a provider and they say, I'll tell you what, if you will do this total hip replacement, I'm going to give you $10,000. Now that $10,000 is going to cover the cost of the doctor, the cost of the hospitalization when it occurs, the cost of the prosthesis that we put in, the cost of the care after the surgery in the hospital, the cost of the care if they go to a skilled facility, the cost of the care if they go to home health, and the cost of the care if they go see the doctor afterwards. But we're only going to give you $10,000. You decide how you want to spend the money and divvy it up. But we're only going to give you $10,000. Now that's going to have a huge impact. The reason it's going to have an impact, if I'm thinking, well, this lady's at such and such a hospital, if I bypass the skilled facility, I can save X amount of money. I'm going to figure out how I'm going to send that patient home. Or they may say, this patient's 86 years old. I have to send this patient to a skilled facility. That's the best place for this patient to do. I'm going to skip home health after they finish at the skilled facility. How we divvy up that money, they don't care. As long as we produce the outcome, we have high patient satisfaction, and we don't go beyond that $10,000. Oh, and incidentally, if you do, we're not going to give you any more money. You absorb the cost. That's bundled care. Value-based purchasing, right now, we're tallying and keeping track of outcomes across the board for everybody, all providers, physicians, hospitals, skilled facilities with the MDS. There's an extraordinary amount of data that the government's collecting on everybody who's providing care. And in the future, my guess is, using that data, we're going to steer patients to the most efficient, highest quality providers. If you have 2 restaurants right next to each other, one restaurant has great food and the other restaurant has poor food, it's a no-brainer where you're going to go for dinner. Well, the same thing is going to be true in healthcare as well. So that brings me to population health management. This is one definition of population health management. The proactive application of strategies and interventions to define cohorts of individuals across the continuum of healthcare delivery in an effort to maintain and/or improve the health of the individuals within the cohort at the lowest necessary cost. Everybody remember the triple aim we just talked about? That's basically the triple aim, without patient satisfaction. And the goals are as follows for population health management. First is to prevent or delay the onset of new conditions. Second is to prevent a worsening of chronic conditions like congestive heart failure or diabetes. And the third is to reduce the risk of acute illness, for example, through immunization programs. And now this brings me to what integrated care is. in an integrated delivery system. It's the provision of comprehensive, coordinated, and continuous services that provide a seamless process of care. What does it mean?
Does it exist?
It's all about providing the right care to the right patient at the right time by the right provider in the right place. It's as simple as that. A lot of rights there. But that's really what this is all about. It's moving patients across a continuum of services at an appropriate time to ensure that they're receiving quality care in the right place. All right, what are the core elements of an integrated delivery system? And remember, an integrated delivery system and population health are intimately entwined. First, there has to be information available to all providers across the continuum 24 hours a day, 7 days a week. So that means if you receive your health care normally in Santa Rosa, but oops, you're in Florida and you get sick, whoever is caring for you in Florida should be able to access your medical records to provide optimal care. Second, to ensure that there's active coordination of care as patients move across this continuum of services, not just at the hospital, not just at the skilled facility, but across the entire continuum. Third, patients need to be able to access care and information 24 hours a day. Fourth, the system needs to be accountable for this whole care delivery model. Not just an individual, not just the hospital, but an entire system. And the system has to assume responsibility for ensuring the quality of care that's provided. There needs to be peer review to hold everybody accountable to ensure that we're using best practices when we take care of you when you're ill. And finally, the system has to be flexible enough that we have continuous innovation. And how does that differ from the traditional care that we've provided for the last 50 years? It forces all of us to be aligned across this continuum of services. We shift from case management to care management. What that basically means is when you're in the hospital, you have a case manager, and that case manager's responsibility is to get you out of the hospital. When you have care coordination or care management, that individual isn't responsible for that little piece. They're responsible for your total care throughout the continuum. It requires system management rather than silo management, much greater focus on patient education, which I'll discuss in a minute. Patient engagement, we want patients actively involved with their care and actively involved with the decisions that are being made. Greater focus on collaboration across this continuum of services. Much greater focus on transitions, and we're going to talk about those in just a second, because all of the above allows us to ultimately move to population health management. So what is this continuum that I keep on talking about? These are some of the participants in the continuum of care. It's basically anybody who touches the patient in one way or another. So it doesn't make any difference whether you're a hospital or a skilled facility or home health or a dialysis center or an urgent care center or a freestanding center or a chronic disease clinic. It doesn't make any difference. Anybody who touches the patient is ultimately part of this continuum of services which we're trying to coordinate.
What about insurance companies?
Well, I was speaking primarily to people who directly touch the patients.
So you know what's really missing from that?
I know exactly what you're going to say.
Most of us in this room.
Well, actually, it's very interesting. I don't think I should share this with you, but I'm going to anyhow. That actually has been recognized, should have been on this slide, and has actually been discussed, certainly on the part of St. Joseph's, including all of you, or representatives from your group, if you will, to participate in the active development of a true integrated delivery system. So your point's well taken, and you're absolutely right.
Sure, you know, because one of the problems is that we don't have members of the St. Joseph healthcare system attending the Sonoma Section on Aging meeting. And this is a very comprehensive group of integrated services in the community that comes together. And the split between the healthcare and the community has been so pervasive in Sonoma County. It'd be nice to see it come together.
Well, I can assure you, well, point well taken. I can assure you it's being discussed, certainly on the part of the acute care facilities. So when one looks at this continuum of care, it looks somewhat like this. It's a patient-centric model. Patients are going to be receiving care in what we call medical homes, And all the providers across the continuum basically report, if you will, to the patient in the medical home, and the medical home will be controlling the care for patients within the system. Now, what's interesting is patients move freely throughout the system. For example, a patient can be in a hospital, they can go to a skilled facility. From the skilled facility, they can be referred to home health. From home health, they can be referred out for dialysis. They can be, when they leave the skilled facility and their home health, they can go back to the doctor's office. Every time a patient moves between one of these levels in the continuum, it's called a transition. And the unfortunate part of transitions is it's when we make mistakes. And this is one of the reasons why the system does not work very well, but I brought some statistics. About half of patients when they're in the hospital experience one medication error.
In the hospital? Or?
In the hospital. It happens at least as frequently in post-acute settings. 1 out of 5 patients discharged from the acute hospital experience an adverse event. Half of patients discharged from the hospital either don't know their diagnosis or they don't know their treatment plan. Labs pending at the time of discharge frequently fall through the cracks, sometimes with catastrophic outcomes. The patient has a biopsy done, nobody checks the results of the biopsy, it's a malignancy. It happens. Physicians communicate with one another about patients only about 20% of the time. And 20% of patients discharged from the hospital are readmitted within 30 days. Many of those admissions would have been preventable had there been a system in place. So how do we try to ensure these safe transitions when patients move from one level of care to another level of care? Well, we have to try to identify risk, then prioritize that risk, find a way of sharing. The EMR stands for electronic medical records, expand community partnerships, to your point, and finally move to care management from case management so we no longer manage patients within silos. There's something called care coordination. Does everybody know what care coordination is? It basically is a system where patients are no longer managed just at individual stops along the continuum, but their entire care is managed throughout the continuum, generally by one person. So that person is intimately familiar with that patient, with their history, and is able to manage those patients as they move across this continuum of care.
How do you decide the one person?
How do you decide the one person?
Yes.
Well, it depends upon who is ultimately responsible for that patient's care.
How is that selected?
Well, if you, for example, are a member of Kaiser, Kaiser's responsible for that. If you're a member of Blue Cross or Blue Shield, they ultimately are accountable for that. If you're part of a foundation that is contracted with an insurance company, the foundation is responsible for that.
So then it's our responsibility, say for instance, we're Kaiser, to ask for that, like care coordinator?
Actually, Kaiser has worked very hard on that, and Kaiser, for complex cases, has introduced care management, care coordination. So they're actually doing much of this. There needs to obviously be tighter collaboration with our community partners. So during these transitions, we were actually conveying the proper information. In most care coordinator programs, certainly when patients leave the acute care hospital, we visit the patient once at home, and then following that, there's telephonic management of the patients, unless patients are really struggling, in which case they're visited more than once at home. But the purpose, of course, is to ensure that patients are able to make a safe transition back into the home environment, that they're on the right medications, and they know how to self-manage. Because, as you can see from the statistics, lots of patients don't know that. And finally, to implement evidence-based solutions. Unfortunately, we in healthcare have had the luxury, if you will, of sometimes sort of doing what we felt is best. And I guess the best example I can give you is there are not 27 best ways to take out your appendix. There are not 27 best ways to treat pneumonia. And we in healthcare, I have to tell you, have had the ability to manage patients in varying ways, and sometimes they're not the best ways. We're now being held much more accountable for evidence-based care, which has been shown scientifically to be the best care that we can provide. Now we have readmission challenges. And this is something to keep in mind. 2/3 of patients who are very sick today weren't very sick a year ago. So it's always a changing landscape. 25% of those readmitted within 30 days. Remember I said we're being held accountable for those 6 diagnoses? 25% of those patients who are readmitted for another reason. But we're held accountable if they were there in the first place for congestive heart failure. They may come back because they fell at home. They may come back because their diabetes is out of control. And we admitted them for congestive heart failure. So what that basically says is, we don't expect you now to just focus on the reason the patient was with you and prevent that from recurring. We want you to take care of the whole patient. So no matter whether if they're going to be a risk of falling at home, you're responsible for ensuring they're going to be safe and they don't fall at home. If they have other diagnoses such as diabetes, you better take care of that too. Not only the congestive heart failure, but the diabetes. Because 35% of congestive heart failure readmissions are readmitted with the same diagnosis, that means 65% are admitted for another reason within 30 days. Now I have to share with you, I'm intimately familiar with that because I'm responsible for readmissions at Memorial Hospital, so I look at this daily. 40 to 50% of readmissions are for psychosocial reasons. And I think everybody's probably well aware of that. At any rate, the bottom line is we really need to address the whole person when we're taking care of patients, not just a specific problem. And historically, we felt we'll take care of the problem, we'll discharge the patient, our job is done. No longer the case. Now somebody asked, how do we identify patients who we feel are patients at risk? And these are specifically patients at risk for readmission. And there's a tool called the BOOST tool. And the BOOST tool examines each of these areas. And actually on any patient admitted to Memorial Hospital, I can tell you the BOOST score every single day. So I know exactly where our patients most in need are located, so that we can look specifically at how we address the needs of this population of patients, which is frequently very different than somebody who comes in for an appendectomy or for some other very simple cause from which they're going to go home and they're not going to have any problems. There are a host of patients who come in who have a variety of problems, and if you add all of those together, those are the patients that are going to be in trouble, and those are the patients that frequently are readmitted to the hospital. Now, I'm just going to go through this very quickly for all of you who like to get into the weeds and you're looking at your health care plan and what it provides and so forth. I just want to provide just a very, very brief overview. When you look at this continuum of services, there's a huge continuum of services. So to get started, you can pick just some major components where most of the trouble lies. Second, you can look at ways of stratifying and targeting populations like the congestive heart failure population or the COPD population. And then you can focus on key areas across the continuum. And key areas across the continuum are what you can do no matter where that patient is across this entire continuum of services. These are generally the major areas that can have the greatest impact upon healthcare. The hospitals, the skilled facilities, hospice, home health, and the providers. And that is not minimizing what everybody in this room does, but this is where most of the big errors lie. You can identify target populations. These are examples of target populations. These are patients that frequently find themselves back in the hospital again and again. You can stratify patients by risk, and that was the BOOST tool that we just talked about. And then you can focus on key areas, and this is what I think is most important, and actually this is what would be applicable to most of you in this room at some level. Consistent medication reconciliation across the continuum. Anytime a patient moves from one level of care to another level of care, somebody should be reconciling their medications. As you know, when you're in the homes, you'd be amazed at how many bottles of pills there are at home. And your mother keeps every bottle of pills that was ever prescribed in case the doctor might prescribe it again because she doesn't want to spend more money. And if you were in my mother's home, before she passed away, it was extraordinary how many bottles of pills she had in her home. I mean, it was extraordinary. So it's important that no matter where that patient is across the continuum, we are reviewing their medications again and again, because that's where we make significant errors. We forget to restart the diabetic pill or the thyroid pill or something else, or it was overlooked, or the patient forgot to tell the doctor in the hospital, and that mistake is carried no matter where the patient goes along the continuum. So everybody along the continuum needs to do what we call medication reconciliation. Second, there needs to be consistent patient education across the continuum. This applies to everybody in this room. What we have done historically is no matter where the patient goes along the continuum, we hand them our educational brochure. We download CRAMES, for example, from the computer, or we've made a special book at the hospital on congestive heart failure. Read our book, it's 70 pages long. I can assure you that unless you're an engineer, 99.9% of patients who go home do not read that material. You come up with what's called a stoplight report. It's 1 page long. That's all. And we now use teach-back. The way we discharge patients from the hospital, from home health, frequently from skilled facility, is be sure to take your water pill when you get home, just like the bottle says. Oh, be sure to take your diabetic pill, and oh, call your doctor when you get home. Well, we know patients don't call their doctors. We've changed the medication in the water pill, so it's a different dose. What teach-back does is the following. Mrs. Jones, can you tell me the name of your water pill? How many milligrams do you take? How often do you take it? And the last question is, Mrs. Jones, how much weight would you need to call in a day before you would call your doctor? How about how much weight you would need to gain in a week to call your doctor? And if she can give you that information back, she is an informed patient who has a much better chance of self-managing her care as she moves across the continuum. And when she makes a mistake, you go back and you use teach-back again. You provide her with the information, and then you say, I just want to make sure I did a good job. Let's go through that again. Can you tell me how many milligrams you're taking? What's the name of that pill? We have not done that historically. We need to make sure that patients have timely follow-up across the continuum. So if a patient goes from the hospital to a skilled facility, they're seen in a timely fashion, because in reality, many times when they get to the skilled facility, they may not be seen for 5 days, and on day 4, they're readmitted to the hospital. When they leave the hospital, we send them home and we say, be sure to call your doctor and make an appointment in a week. How many patients do you think really do that? They don't. They don't generally until they get into trouble. We need to provide timely patient access to care across the continuum. That's why patients should be able to call and make an appointment themselves on the computer, or they ought to be able to call the office. And the office doesn't say, I'm sorry, the doctor's booked until 3 weeks from next Thursday, but rather we have an opening this afternoon and we will see you this afternoon. Because many of those patients, because they're not seen for 3 weeks from next Thursday, they're back in the hospital before they even see the doctor. We need to obviously be able to expand the electronic health record across the entire continuum, so no matter where the patient is, we can access the same medical record, same information. We know exactly what the patient's medications are. And finally, timely and appropriate care, palliative and hospice services. 75% of patients, when given a choice and when queried, want to pass away at home. 75% of patients die in the hospital. That's not what they want. Other areas, obviously, are care coordination across this entire continuum, timely and complete discharge summaries. We expect doctors to see patients within days of discharge from the hospital. The reason for that is if you're sick enough to be in the hospital and we're sending you home, and as you know, lengths of stay are getting shorter and shorter, we want those patients seen in a timely fashion. We don't want them seen 3 weeks from next Thursday. Well, when they see that doctor in 2 days, they need to know what happened in the hospital. And the only way they know that is that they're getting timely and complete discharge summaries. We need to obviously utilize best practices across this entire continuum so everybody's doing the same thing. And finally, we need to cultivate community partnerships. So it's a proactive system of healthcare, not a reactive system of healthcare. It's patient-centric, model is a medical home. It provides the complete continuum of services, not just in a silo model, but in a coordinated fashion. There needs to be easy access to health care. Patients need to be empowered through consistent education across the continuum. It needs to be cost-effective. We need to use best practices. Patients need to have access to palliative care, hospice services. They all need advanced health care directives. And we need to have an electronic health record to drive the whole system. Let me come back just one more time, and this is specifically pertinent to this group, and that is make sure all of your patients have advanced healthcare directives, or you have at least asked the question. Do you have an advanced healthcare directive? Do you know what that is? Do you have an interest in learning more? You don't have to push it. They did, there's, everybody know about La Crosse, Wisconsin and the Gunderson Clinic? In La Crosse, Wisconsin, 94% of patients, of individuals that live in the community have advanced healthcare directives. They have the highest patient satisfaction and the lowest healthcare costs in the nation.
Wow, that's pretty interesting.
So I find that striking. So the goals, obviously, of population health management and an integrated delivery system are to optimize the management of chronic conditions, prevent or delay potential new chronic conditions, and to keep all the rest of us healthy. And the way we do that, or what is asked of us with the Accountable Care Act, are the AIM measures: improve quality and outcomes, minimize costs through efficiencies, and finally improve patient satisfaction. So in summary, I think it's safe to say healthcare is changing. It's going to impact everybody in this room. It's coming faster than most people recognize. We are all now accountable for the care beyond our walls, as all of you get welcomed, if you will, into this whole system. Care continuum, expect to be held responsible for the components that you provide as part of the Continuum of Services. We want to improve the care of the patients for optimal outcomes, and the IDS is a model which leads us to the development of a true population health management model. Educated patients are empowered patients.
That's true.
Educated patients are much more sophisticated consumers of healthcare. So the more information patients have that is presented at an appropriate level of understanding. In other words, most people read at a 6th grade level.
No. There is no microphone. Yeah.
I was just saying that educated patients are empowered patients. They're much more responsible at managing their own care. One of the mistakes that we have made in healthcare in the past, at least my opinion, is we have made patients dependent upon us rather than giving them the tools where they can self-manage. And I think that you're going to find a big shift going forward in how we empower patients so that they're better consumers of healthcare and they can manage themselves.
I have a quick question about the pool of money for that fractured hip that we were talking about. So they're going to give us $10,000 to take care of that. And if the costs overrun, the costs have to be absorbed by somebody. Is that going to be the patient?
No, it's not the patient.
Really?
The patient is at no risk. It is the providers who are at risk.
It's going to be a mass exodus of physicians.
No, I don't think so. I think that what we will do is we will learn to more efficiently provide care.
There'll be a lot less tests that don't need to be done, medications that don't need to be prescribed.
There are probably going to be medications that are not prescribed. Of course, the fear for everybody sitting in the room and for the public in general is we're going to start cutting corners, and it's going to impact the quality of care that's provided. We waste so much money in healthcare today. It's astounding. I personally don't think it's going to change the quality of care at all. And one of the things that got a lot of press not too long ago was this whole issue of, well, they just want to cut off support for my care, or I have a terminal disease. I think we are going to have tough decisions in healthcare. Do we do bypass surgery on a 90-year-old? That's a philosophical question. I don't have the answer to this, but that's going to be a question that's going to be asked, and maybe appropriately so. As you know, we spend.
Who will
Sorry?
decide that?
Well, you see, I personally think that's something that's decided between the physician and the patient.
But how about that one person? Would that person decide that?
I'm not sure I understand.
You said you have a continuum of care.
Care
So
coordinator.
much-
Care coordinator.
And one key is a coordinator.
Now, the quick care coordinator is there to ensure that the patient is receiving care that is consistent across the continuum. They are not there to make clinical decisions. They are not there to make that kind of determination.
Thank you. Thank you.